All right, this will be fun. Can everyone hear me okay? Ooh. Okay, great. Well, my name is Norman. We'll kind of get started. As we go along here, I just want you guys to remember a couple of things. One, our time is kind of limited, so if you have questions, feel free to ask at the end. And then we'll be going through questions as well for the test and everything else at the end. And if anything doesn't sound right or you disagree, just remember my name is Joshua Minori, okay? All right. They asked me to submit a picture, so I wanted to get the best part of me in there, and that's the lady on my right, my dear wife. So I have no disclosures, and I don't think Romikowski does either. I'll pay him later, but there's Joshua, he's great. He'll forgive me later. And then wonderful Joy. All right. Acknowledgements, we'll kind of get through this, yada, yada, people who help advise. As we go along, we'll be talking about the physiology of pain, how it relates to the concepts of pain management, assess patients in pain, develop a safe and effective pain treatment plan, and identify the evidence-based non-opioid options. I'll be talking a little bit about that, but also identifying the risks and benefits of opioid therapy, managing ongoing opioid therapy, and recognize behaviors that are associated with opioid use disorder. Let's get started with cannabis and pain. Those are the developers and viewers. You can email them or send them complaints about anything you see that you don't like here. A few things we want to talk about with cannabis. I feel like I'm going to stand in the way, but oh, great, wonderful. Couple points here. This cannabis and marijuana, obviously it's the most illicit use substance in the U.S. right now. Some of the main concerns that we see are the growing trend, particularly among young users. If any of you consider prescribing cannabis, you should also be aware and ask about the family, who's in the home, do they have access, and things like this. We are seeing that commonly with those 12 or older, and even in the young teens, we're seeing a growing trend there. Even with those 18, 19 and older, we're starting to see, as I mentioned, 44% of people 19 and 30 have used it, and with daily use 11%. Interestingly enough, a study was done with those who are teenagers, or at least seniors in high school. We're seeing about 6% of the U.S. Has been using marijuana as high schoolers. In cannabis, it's got over 500 compounds, very complex. What we see is the cannabis itself, as you can see in this picture, is stored in the trichomes, those little appendages that are on the plant. The most common species that are typically used are that of the sativa, the indica and rudularis. They typically will have different and varying concentrations of THC. Usually the sativa has higher concentrations of THC, and the indica has a little bit lower. And rudularis typically has more concentration of CBD over THC. In the chemical composition of it, there's 100 cannabinoids, actually about 180, 181. THC is obviously the one that has the most negative effects, or the psychotropic effects. With that, CBD is also being studied. But typically what we see is that the best data that we have with CBD is that it's very beneficial for those with rare epileptic seizures and disorders, Lennox-Gastaut syndrome, and others. But there's no real indications by itself, at least it's been FDA approved for pain. As you'll see, the preparations are often labeled, and we'll talk about that here in just a minute, though, with THC and CBD content. So what we're meaning by that is basically, because it's a supplement, there's not a lot of strict regulation on that, and so the concentrations can vary. The FDA has done studies where they pulled it from the market just to test it, and they found that the actual content of CBD varies as well as the content of the THC. And as we'll see in, I guess, the next slide, the percentage of THC and CBD in cannabis samples that has been seized by the Drug Enforcement Administration or agency has been actually increasing, particularly in the THC content. And the CBD is relatively stayed about the same with that it's been. The newer cannabinoids patients are now being exposed to and they're currently in use. They're also out there at dispensaries. We'll see cannabinol, CBN, that's actually been around for a while. Interesting enough, in China, there was a tomb, I believe from one of the emperors, back in 750 BC. They had this all over in their tomb. But it is less potent than THC. People will find that they typically won't get as high off of it unless it's at really high amounts. It's often used for sleep disorders, depression, anxiety. So if you do see it out there, typically those who are struggling with sleep may consider this. But there hasn't been any rigorous studies on it to show if there's significant benefit or not. It still needs to be further tested. CBG or cannabigerol, that's been around as well. This is typically what's considered to be the mother of all cannabinoids. You'll see, and you should know that in various plant species, whether it's, when we think of marijuana plants, they typically have more enzymes that will convert CBG to THC. And hemp plants, which contain a little bit less THC than marijuana plants, they have more enzymes that will actually convert the CBG to CBD. Hence the precursor itself to other cannabinoids. The theoretical anti-inflammatory properties have actually been studied. It is showing the potential benefit there, but there's, again, no rigorous studies for that, but it is used in pain management in some cases. Preparations of marijuana. Just a small brief thing on this. You should be aware of some of the terms that are used out there. Hashish, that's been around for a while. Typically that's found in a lot of Middle Eastern countries, Europe. They will use that. Tinctures, that's the cannabinoid liquid. You can get that, again, around in dispensaries and other shops as well. Hashish oil and infusions. These, to make it a little bit more pleasing, you'll sometimes see infusions in coconut oil, but even in coconut oil, they'll use that just for the flavor of that's a little bit more pleasing for some. Again, these are some of the preparations and packaging. One of the interesting things, I had to look up the potato chips, but they really do have this. I noticed that in the picture, but you'll see that you can actually get cannabis potato chips. It's about $34 a bag. And so again, some of the medical containers, you'll see at the dispensaries how it's used. I don't want to spend too much time on the synthetics, but you should be aware about this also. This is a growing trend. We're actually starting to see more of this, these synthetics. I had a patient who let me know that she'd used spice before, which is a synthetic that's out there. You'll have others. You may have what's called hillbilly heroin, as they call it, or the kush or black mamba. Some of these preparations, the hard part about it is these preparations are out there. They found that typically, if you're trying to do a urine drug screen, a standing urine drug screen is not going to pick it up. But if you use liquid chromatography and mass spectrometry, which typically you're going to be targeting the JWH compounds like JWH18 or 73, those might pick it up. But because there's because the metabolites are changing, it's an ever-changing world. These are far more dangerous. They're going to have far more psychotropic effects, greater addiction potential, and aggressive behavior on the individual, potential for other adverse effects. But if patients use these, or if you're worried about it or common, you need to advise about it to them, to their families, to be aware about this and to try and avoid any use of synthetic products. Some of the mechanisms, some of the theoretical, We'll see here that the endogenous cannabinoids originate obviously from the postsynaptic membrane. They'll act on the presynaptic cannabinoid receptor as seen here. This will then modulate the release of the transmitters, particularly dopamine. And THC has such a high effect on this that it will release more dopamine into the system. And exogenous cannabinoids co-opt the system, particularly the THC. It can affect the 5-HT, TRPV, and TRPA receptors. Theoretical mechanisms for analgesia, we'll start to see this. Typically, as cells are in injured tissue, they will release endocannabinoids, anandamide. The CB1 and CB2, these are your cannabinoid receptors. CB1 is typically found in the brain and in the central nervous system, but more often. And then the CB2 receptors are typically in the peripheral. You'll see those in the spinal cord. They help to reduce the inflammatory response. The CB1 will actually help to mitigate sensation, inflammation. But again, exercise, we should be exercising caution with any drug where the subjective pain improves but has the addictive properties. And CB1 is the one that particularly is responsible for the THC or the psychotropic response. Perceptions of medical efficacy versus the data. A lot of people, 81% according to this, felt that marijuana has at least one benefit, and 66% felt that there's potential for at least pain benefit from this. What the data is showing, though, in a systematic review of random controlled trials in 2021, the outcomes have low or very low quality evidence, and so there really wasn't a lot of support for that. And the meta-analysis in 2022, they found that placebo actually beat out marijuana response. There was a question about why was that when I further looked into it. And the answer was the marketing. They felt that the marketing response was so much that it helped people, if they hear, hey, this may help you, placebo goes a long way. The review of 2022 high THC CBD products, there was some potential associated with the 25% reduction in short-term studies of variable quality with that. So that one is a little bit in question. Opioid sparing theory versus data. If cannabis products treat pain, patients may use those products and reduce their use of opioids. As you can see here, there's actually, and if you go into, if anyone has questions on this, feel free to ask me after. But interesting enough, the studies kind of went back from 1999 to 2010, and they were showing that, hey, maybe this is kind of limiting the use. People are limiting the amount of opioid use from that time. However, what they found was, from another meta-analysis that was done, that actually it was in the reverse. That they found that if they took the data all the way to 2017, and those states that were allowing for medical marijuana use, they actually found that there was increased opioid use and increased opioid use disorder or deaths occurring. So there's very low evidence, unfortunately, and they really came to no conclusion that the use of marijuana, because of the conflicting data, may or may not reduce the amount of opioid use in some patients. So the cannabis, as I mentioned down here, the one review, cannabis impact on the use of opioids remains insufficient, at least right now. So well, that's more to come. Psychiatric components. Now, medical indications from the the American Psychiatric Association. They've issued a statement against its use with cannabis as medicine. There's not well studied for the use of any psychiatric condition. Now, that being stated, CBD, and there is actually some evidence that, hey, this may potentially help with some anxiety. Talking with, and I'll come back to this actually. If you use, and we'll come back to the use of dronabinol and some of these other medications which are used, as I mentioned here, for anorexia, nausea, vomiting, and I mentioned about the CBD use for the like Draval, Lennox-Gastaut syndrome, these rare childhood forms of epilepsy. It's been FDA approved for that, and CBD has actually shown better effect on some of these rare forms of epilepsy than some of the regular recommended medications. So there is potential benefit there for that, for the CBD for those. And again, I've used dronabinol in a patient who, with extreme nausea, vomiting, G-tube, couldn't tolerate it, and that was helpful for her at the time. And again, I mentioned briefly about dronabinol. It's just in this one. The good thing about these medications is these have been tested. You can regulate the dose on these for those who with anorexia, wasting, and AIDS patients, nausea, vomiting, chemotherapy, cancer patients. Nabilone, dronabinol can be used. Cannabinol. Again, the CBD, as I mentioned, has had a significant benefit for those with these rare forms of epilepsy and childhood epilepsy. If anyone has questions on that, feel free to reach me after as well. Clinical considerations though. If you have a patient who has a family history of schizophrenia or a family history of bipolar or some mental health conditions, be careful. There is a potential risk, particularly with THC, that it could flare those conditions up. Baseline psychosis risk related to driving, work, education, and obviously some medical and cognitive issues can be worsened by cannabis. Some people may be just fine, but it's important to know too, what their condition is. Do they have a history of it, or any other psychotic conditions in the family? Right now, federally, cannabis is illegal. It's been approved by some states. It's likely to change very soon and brought down, as we understand, to a Schedule 3. With your patient, review the harm reduction strategies. We'll go over those in just a second. Abstinence, particularly in young people, is the best way to avoid health risks. They knew in one study that was done in New Zealand, they found that youth, particularly those 12 to 18 who were using cannabis, they lost about 8 IQ points. And later on, when they stopped using it, it didn't come back, meaning that it had a permanent effect. However, when they tested that in adults, that was not the case. But for youth, particularly with ever-changing and growth, it is something that we need to be more aware of and avoid the early age initiation. Avoid high-frequency use, daily or near daily. If we're considering THC, we really want to consider using a low THC or a balanced THC-CBD ratio when we do it. Avoid combustible products, avoid use in older adults due to risk, and abstain, obviously, from synthetic products. The risk inhalation. Now, typically marijuana, if you're smoking it, you'll find that there's a lot of risks it's just like nicotine. Matter of fact, there is some argument from the American Thoracic Association that there may be more risks associated with damage to the lungs than with nicotine. And so, it can encourage people to avoid smoking. Typically, the reason why it is smoked, you get the effect in 30 minutes. If you use an edible, the effect may take a couple of hours. And if edibles are considered or they're prescribed or either, you need to caution patients and let them know that an edible will take longer to take an effect. Many people, if they don't notice the effect, they will take more, and unfortunately by that time, they've actually gone higher than they intended. And so they can have adverse effects with that. High-risk populations, we mentioned about that. Track use over time, including meter dosing. If you're considering it, start very low and then go slow with it. Set a time and a limit. Don't make this a permanent thing. Long-term use, we start to see more adverse effects with that. Try to consider limiting the amount if you can. Substance kratom, this is a fun one. This is found in shops everywhere. In smoke shops, this is found sometimes in gas stations. I had a patient once, when I asked them what they're using, they said, God's Pharmacy. And they're like, oh, okay, great. Now, you can, urine drug screens, again, just a standard urine drug screen is not likely to pick this up. liquid chromatography can. But you have to probably specify that if you're seeking for it. The prevalence about last year was about 1%, 8% to 1.3. Obviously, it's not a cannabinoid, but it has similar opioid effects. Some people, one person I knew, a friend of mine, actually, he told me he was using it to help him. If you use it at low doses, it can actually help you to feel a little more energized. And he was trying to, because he felt tired all the time, so he was trying to use that for that. If you take it in higher doses, it actually has the reverse effect. It can make you feel more sedated. There's no medication treatment, really counseling patients. I actually ended up sending my friend to a treatment center where he was able to get off of this, because the withdrawal effects are similar opioids. It's binding to similar opioid receptors. You should treat it and actually try to help them taper off or come off, and consider treatment centers if needed. Okay, I think that's references, yada yada. Really quick as we get into this, reduction of opioid, we're going to now switch our gears for a second and get into opioids. Reductions in opioid prescribing have not necessarily led, though, to reductions in drug-related mortality. Now, just recently they announced in 2023 that the number of overdose deaths has actually decreased to about 100,500. That's about 21 less. That's not much to get too excited about. There's still quite a ways to go. You'll see that in 21, the number of opioid prescriptions has been steadily decreasing over time, and we should continue to try and work on that when we're considering opioid therapy. Now, with prescribing rates and overdose deaths, you'll see that Utah, the prescribing rates per 100 people has been steadily declining. I think back in 2012, it was crazy how high it was. We were the fourth. I think we were marked number 4 as for the top opioid prescribers in the nation at the time. In 2022, compared to the overdose deaths compared to the U.S., ours was significantly lower. However, the data is a little bit skewed. If you were to look at data, you'll find that in Utah, we tend to be a little higher when we talk about morphine equivalency than 90 milligrams or more. We tend to be leading that, unfortunately, or above the U.S. average. And so, we tend to be below the U.S. average, typically below the 50 milligrams morphine equivalent or less. Opioid overdose deaths by type of opioid. Obviously, you'll see that any opioid, there's been a steady incline or a steady increase with that. Synthetic opioids other than methadone, particularly with fentanyl, that has been continually increasing. What we find here in Utah is that more people, though, are dying by opioid prescriptions than they are with the use of heroin, and so, or methadone. And then just really quick on the prescription drug monitoring program, really we should be looking at Adopol every time. If a person has been prescribed an opioid, automatically we should look at Adopol. If they live on a border, if there's concern, I have some patients who live in, patient lives in Wendover. They've gotten their prescription on one side or the other. I've talked to the pharmacist to have them look at the Nevada, but we can actually look at the Doppel or their reports from Nevada as well. You can access Doppel, and they have the reports from different states, although not all pharmacies, as they mention here, are required to do that. But when I say all pharmacies, I mean out of state. But look at the Doppel, and again, consider other states if there's any question on that. Let's see here. Obviously, this is why we're here, just simply because the requirements, the 4 hours every 2 years. I think we can go through that. The prescribers in the naloxone, this has been made easier for everyone here in Utah, particularly they're allowing, as I mentioned here, by standing order. Pharmacies can just give it out. If you go to any Salt Lake or any county library, you can get it for free. If there's any trouble with patients trying to get this, I will send them to a library, and they can get it out. They just walk in and ask for it. They'll hand it to them. Unfortunately, we see that libraries are common places where people will overdose.
Do they have to have library cards?
No. You gotta be awful bad being good over standing and good over. There's actually some pharmacies, like the Apothecary in Salt Lake, they'll hand it out for free as well. You can go there. And then, now, I'm going to make one brief mention on this. Some patients say, what do I do when it expires? I say, hold on to it. One of my patients actually gave it to their daughter who was hanging around with other athletes who were unfortunately using opioids. And he had given his old prescriptions. We don't know how long this lasts, but obviously they can last. There's some reports even up to 30 years or more, but we just don't know. And so this daughter, actually, when one of her fellow athletes passed out, she used it on her, helped save their life with an old naloxone prescription. So hold on to them. I've actually had to use one in the clinic when someone wasn't waking up. But state requirements, obviously, they require 8 hours of treatment, management patients with opioids or other substance use disorders. If you've had buprenorphine training, I believe that counts as well. All right, I'm going to turn over to Dr. Mikowski.
Great job, Norm. That was excellent. So now we're going to get more into pain. You know, you guys are here for opioids, pain, strategizing, figuring out how to best kind of manage patients with pain, which I'm sure all of you see. Put this back on here. I don't know if I'll walk around as much as Norm. He's got a lot of energy here.
Yeah, please stay here.
What's that? Stay here?
Yeah.
Okay. Are you still recording?
Mm-hmm.
Oh, okay. It's working. Okay, so chapter 1, this is all about pain, and this picture that they actually changed this year is to help demonstrate how sometimes people refer to their pain. Less pain is like more of a blue color, more pain is a red color. So this diagram kind of shows nerves and nerve cells and how that kind of interacts in the patient and how they would describe some of their pain. But the objectives of this part are to differentiate the common etiologies, neurotransmission, and neuromodulation of pain, distinguish between acute and chronic pain, distinguish between nociceptive, nociplastic, and neuropathic pain, which Dr. Minori, I think, talks about as well. Identify the body's homeostatic mechanisms for resolving pain, and then recognize the relationship between one's physical, psychosocial, and spiritual health and one's experience of pain. You just arrowing it? I guess so. Maybe we'll do this. Okay. I'll just do it with the mouse. Okay, so neuromechanisms of pain. This is usually a slide that is a video and it comes in, but what I want to first talk about, which I think is a little strange in this discussion, is we're using the word pain, but we don't really have a definition of pain. So I always like to go into the International Association for the Study of Pain, the IASP, and their definition, because this is kind of a common ground that we've all kind of laid upon so that we understand what pain is. And when we talk about it, what are we actually describing? So the revised statement happened in September 2021, and it states, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So when we talk about pain versus nociception, or that experience of pain, nociception really is the body's ability to detect that there's some actual or potential tissue damage happening. And then pain is this coalescence of all the nerve signals and the transmission that goes to your brain and how that affects your experience. So without the nerve transmission to the brain, we could just have nociception, but it wouldn't cause the debility and the experience that we have, because it would not go up to the brain. So in this picture, we go through kind of an example of the neuromechanism of pain. So say Joe here, Joe Bag of Donuts, he steps on a tack, and that tack causes a nociceptive response. So there's little receptors within our periphery that notify the brain that there is something happening. So really, these specialized fibers and these sensory, the input from that particular insult goes through nerves, and the main nerves that they travel through are the A delta nerve, which is a thin myelinated nerve, so it happens very quickly, and that travels straight up very quickly and will cause a localization. So this is really how you can localize where that pain is. It also travels through C fibers, which are unmyelinated. They're big. They're a little bit slower, but that also helps with like a generalized localization of where the pain's coming from. And then there's A beta fibers that are large and myelinated, so they're very quick, and that's more like proprioception and some temperature along with that. So you get this insult, it travels along this nerve, and then it goes to the spinal cord where it'll synapse, cross, and then travel up that spinal cord, usually in the dorsal column, and go up to the brain. So we see there's modulation points at each area here, and the next slide kind of gets to that a little bit more. But we need to be thinking about areas which an opioid is going to be helpful, or some other peripheral ways of treating this pain at its source. So NSAIDs, local anesthetics, those type of things. So as it travels up to the brain, it goes to a couple of different really important areas. So this nociceptive response travels up, and it'll go up to the thalamus, and then that thalamus will then redirect that to our sensory cortex. And so you know that diagram where you have your somatosensory cortex, and there's an arm and a leg for parts of your brain that process this. And so the thalamus really helps direct that. But on the way up, it'll also go through a couple of different areas that are important. So the reticular formation in that brainstem is important for sleep-wake cycles. So when that nerve transmission goes through that region, that's why we pop up. We're awake. We are stimulated, right? And then it'll also go up from that thalamus into a couple of other really important areas. The limbic system, for one, is very important for emotion. So the amygdala and the anterior cingulate gyrus all process emotion. So that's the emotional portion to why we experience pain in the way that we do. Some other areas, the hypothalamus gets stimulated as well, and that'll go into our sympathetic nerve response. So fight or flight, pupils dilate, we start sweating. These are all very characteristic of pain. So really important areas here. So we have modulators at each section. So there's some peripheral pain modulators like histamines, prostaglandins, substance P, there's VIP, CGRP, you name it, we've got it. And so those all kind of propagate these pain signals as well. And the body's pretty elegantly designed. You know, we have some descending neurotransmitters that can help block or inhibit some of the pain signals that we are experiencing. So examples of that are serotonin, norepinephrine, some of the endogenous opioids, or opiates, I should say. So the enkephalin and dynorphin and beta endorphins. So mediators. So once again, when we have this insult, so there's that injury, there's that pinprick, and things just start ramping up. So we have all of these different substances. Once again, we have some substance P and mast cell degranulation, histamine release, bradykinin, 5-HT, prostaglandins. All of these things help propagate that nerve transmission. And there are areas that are important here that we kind of briefly discussed, but it'll go through the dorsal root ganglion and then to the spinal cord. So there's ways that we can help modulate that in the process. One thing that we should really be thinking about is how do we treat what's happening at this peripheral tissue level. So anti-inflammatories, lidocaine, local anesthetics, ketamine, all of these things can actually be beneficial to stop pain where it starts, as opposed to thinking about an opioid that's going to go kind of everywhere. And we'll get to that in a couple of slides. But the dorsal root ganglion, very interesting. This is kind of where we can target with neuromodulation. Peripheral nerve stimulation can help neuromodulate how these pain signals are actually transmitted through these nerves into the spinal canal. And then dorsal column spinal cord stimulation can also block it more at the spinal cord level. So like I said, you know, opioids they go everywhere. We have mu opioid receptors throughout our body, in the intestine, in the gut, you know, in our respiratory system, respiratory centers in our brain. So when we think about providing opioids to patients, we really need to think about how systemically they're going to affect them. So in the intestine, obviously, you know, that can cause increased constipation and be very debilitating for some patients. So when you're prescribing an opioid, always think about the other systemic effects that can occur. One important thing on this slide is, you know, where would we optimally love an opioid to go? Well, spinal cord, there's actually the substantia gelatinosa, which is what we target from an anesthesia standpoint with a spinal anesthetic. We want the opioid that we put in there to go to the substantia gelatinosa because there's a high number of opioid receptors there, predominantly in the Rex lamina number 2. That's the substantia gelatinosa. But there's also a lot in Rex lamina number 1 and number 5 as well. And then up into the brain, where we would love it to go, is the periaqueductal gray area. There's a really high number of opioid receptors there. Unfortunately, it goes other places too, right? So one thing that we worry about in patients that we see is you never know who is going to be more affected by an opioid when it comes to that euphoric sensation that you get. And so that happens in the nucleus accumbens and the amygdala. This is that emotional response. So I would say any patient that you are treating with an opioid that has anhedonia or is just a low tone there, they might be actually at higher risk of developing opioid use disorder or a substance use disorder just because that euphoric state from taking an opioid medication might be much higher. Not everyone responds that way. Some patients, Dr. Oki used to say, his brother, very low when it came to the euphoric effects, but he took opioids one time and he really liked it. And so that really scared him. And knowing Dr. Oki, who's been part of this lecture series in the past, it scared him. And so he always goes into that data and that information with patients because it can affect everyone a little bit differently. Okay, so back to, this is where they ended up putting that slide, but it really just goes back into pain and the definition of pain. So we see it there once again. And I always like to note that there's actually 6 key notes that the IASP adds to this definition to make it a little clearer, to make it a little more understandable, and to put it in perspective, really. So the first kind of key note that they put in there is, I'll just put this here, pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. Number 2 is pain and nociception are different phenomena. Pain cannot be influenced solely on activity in sensory neurons. Number 3 is through their life experiences, individuals learn the concept of pain. Number 4, a person's report of an experience as pain should be respected. Number 5, although pain usually serves as an adaptive role, adverse effects can happen with function, their social well-being, and then their psychological well-being. And number 6, which I think is very important, we should always kind of keep in mind, is verbal description is only one of the sensory or one of the behaviors that we use for expression. Therefore, the inability to communicate does not negate the possibility that a human or non-human animal experiences pain. So our pediatric population, our geriatric population, those who cannot communicate verbally, doesn't mean that they're still not experiencing pain, so we need to respect that. And then we get into acute versus chronic. So we're kind of going a little bit away from these definitions, just because it's on a continuum. And so every patient's different. We really need to think about that. But traditionally, we think of acute pain as less than a month, sudden onset, self-limiting, usually resolves, can heal, triggered by that kind of nociceptive response and the tissue damage. It does serve as a protective role. And then, after that month, we get into this subacute phase of like 1 to 3 months. However, once again, it's on a continuum. So there was an interesting lecture that I heard from the American Society of Anesthesia. It was about 2 years ago, and there was a provider there who's done a lot of work with pain and acute pain in particular. And he kind of refutes that this is an acute or chronic, because chronic can develop very quickly. And some of the data that he supported was as soon as 3 weeks, 2 weeks after a surgery, you can develop a chronic pain syndrome that may not be treated as a chronic pain syndrome because it's still in this acute phase. So we might be missing a whole population of patients if we don't kind of think of this more as a continuum. Chronic lasting more than 3 months, generally steady state or worsening, serves no role, unfortunately, but millions of Americans affected by it and millions throughout the world. There's peripheral and central sensitization that can occur as well. And this is more of this aberrant firing of these nerves that are hyperstimulated over the course of time. So it changes our perception. Lots of types of pain. Nociceptive or inflammatory, we really went through that with Joe Bag of Donuts stepping on the tack. It's a painful response to an injury, typically acute. So some examples would be like postoperative pain, sports injuries, sickle cell, mechanical low back pain. Nociplastic, this is more of a hypersensitivity once again, so it's this in-between neuropathic, nociceptive, and it's usually without specific tissue damage. So an otherwise, normal MRI, but then there's, this nociplastic type of pain that develops, and we think of it more so in the context of the type of diseases that we treat, the pathologies that we treat. So fibromyalgia, irritable bowel, non-specific low back pain, all of those things would be termed more as like a nociplastic pain. And then we have neuropathic pain, and that's developed when there's damage to the nervous system, really. And this is a chronic type of pain, burning, tingling, sometimes even itchy. And we think of it more, once again, in the context of the type of pathologies that we treat, which would be more like a postherpetic neuralgia, trigem neuralgia, CRPS, and then neuropathic low back pain. Then there's mixed types, a combination of the nociceptive and neuropathic pain. And then there's a last one is psychogenic pain. And this is, pain outside of identifiable kind of tissue injury or debility there, but more so with stressful mental health issues, depression, anxiety, all of those things that can really change how we sense pain. Somatoform, those type of things. So how do we experience pain? Well, we always try to think of it as holistically as possible, at least I do in my clinic. And I always try to say, when I'm speaking with a patient that has pain, that it affects every aspect. That's the hardest part about treating pain. It affects every aspect of your life. It affects you mentally, psychologically, physically, spiritually, socially. The way people interact when they have pain, they feel very isolated a lot of times because no one understands it. So in our clinics, we really try to be integrative when it comes to treating this patient as holistically as possible. And we take into account the biopsychosocial model. And so what type of things, we need to look at this through the lens of the patient, what type of interactions have they had throughout their life that can be affecting how they're experiencing their pain. And so social factors, like we see there, biological factors, are there other things that we can maybe address to really decrease their painful situation. And then psychological changes, we know for a fact, data would support depression, anxiety, all predispose or worsen pain syndromes. So all of this, they all come together and it affects function. So yes, in our clinics, we really try to decrease the amount of pain people are in, but really we're trying to follow function and functionality. Because living with pain is pretty consistent. We've all had it. I can guarantee it in one way or another. But when that pain starts to interfere with function, that's when we really need to try to intervene and do everything that we can from a holistic standpoint to treat these patients. So adverse childhood experiences, ACEs, we want to shift the focus from what's wrong with this patient to what happened to this patient. Some interesting numbers here. It says that if you've had an adverse childhood experience, you are at a 70 to 170% increase of having worsened pain, which is pretty interesting. So we have to think about trauma, and trauma really, if you've had a traumatic event in your life, that predisposes you to having more pain, unfortunately. And I think all of us can agree we've probably all had some sort of trauma in our life. So it's something that we have to ask our patients. How do we identify this? Are we getting the right treatment? Are we seeking the right individuals to help treat these traumatic experiences? And you can see on there quite a number of them. So chapter 2. Let's get to chapter 2 because there's some objectives here. And there's a little bit of overlap in some of the things that we're talking about. So I apologize, but that's just the way that these slides were designed. But the learning objectives for this chapter are determine the elements of a patient's history and physical examination needed to diagnose a patient in pain, and then identify the key elements of a PDMP record to consider prior to formulating a treatment plan. So how do we initiate a discussion? We get into a little bit of terminology, and main point of this slide, we don't want to stigmatize, right? So there's certain words, and words have value to people. And we need to make sure that we're as respectful and honest with those patients and to not offend or stigmatize whatever they're going through. So terms we like to avoid nowadays are addiction, although addiction is a very important word, and there's a whole specialty designed to deal with addiction. In a patient setting, it's a little bit tougher to talk about it. And so addiction can be one of those stigmatizing words. So what we'd like to use now is substance use disorder or opioid use disorder. And drug seeking, aberrant, problematic behavior, you're just not using the medication as prescribed. So we need to really discuss why. And so these are ways that you can discuss that with your patient. Addict or user, it's a person with a substance use disorder or an opioid use disorder. Let's identify that and let's manage it. Dirty urine, failing a drug test. I would hate for a patient to come in and say, "You got some dirty urine." I don't think I would take that very well, and I'm pretty sure patients don't as well. So you tested positive. Let's talk about why this came up. Because there are inaccuracies within our lab testing system, but there's also things that people might be taking, like Norm talked about, that could actually have substances in it that people didn't know about. So let's talk about it. Don't just write them off and say, "Nope, you're out of my clinic." You gotta address the issue. And so abuse or habit, misusing, other than how we prescribe it. We prescribe your oxycodone 5 milligrams twice a day. You've overtaken that medication. What's going on? Why are we short on pills? Is there someone in the home? Are we diverting the medication? All of those things. So open communication is really the key point to this. So how do we get to pain? Like someone comes into your clinic, I'm sure if there's primary care providers here, that's 13 on the list after your diabetes and your cholesterol that you talked about. So pain oftentimes gets kind of put in the background, and then the easy way to deal with it sometimes is just the 5-minute conversation as opposed to the 5-hour or 30-minute conversation about an opioid, right? So we want to go through and figure out what is painful. And how do we do that? Just like you would work up anything else, we want to go through a good HPI. So we pre-screen with some questionnaires to help identify maybe depression or anxiety, or just a brief pain index to really identify how that pain is affecting their lives and where it's located. Then we go through our own kind of history. Old carts is something that I still use, always use. It's a very good way of kind of figuring out where's your pain, how is it affecting you, what exacerbates it, what alleviates it. And then you go into kind of more of the emotional experience. So once again, that holistic way of talking about pain and a patient in your clinic with pain, you got to address all of the factors, because there might be some underlying things that are much easier treated than just here's some medication or here's PT. We can really get to the nuts and bolts of it. And so an integrated approach with the use of psychology, physical therapy, chiropractic, whatever means you have to do this as non-pharmacologically or pharmacologically without an opioid is the best. So medical treatment history, what relevant illnesses, especially someone on opioids, you got to really figure out if there's issues with their liver, their kidneys, any cancer, any heart disease. All those things can affect how we metabolize opioids or other medications, but also can maybe lead you down a pathway of determining what type of pain this patient's suffering from and how best to augment your therapy to treat it. Always go through your past and current opioid use. You query your state's PDMP, like Norm said, preferably every time. And in a lot of our clinics who focus on pain, we do that every time. Because I want to know if someone's getting medications elsewhere. And that I'm the only one prescribing, because that's one of my medication management agreement rules, is that you will not be getting opioids from anywhere else. If you have issues, you contact me. And we talk about it. We bring you in. We assess. These phone calls where, I'm in more pain, so I went to the ED, I got another prescription, but I am already using your prescription. That just gets really muddy, and it puts a patient at increased risk of overdose, respiratory issues, even death. So determine whether the patient's opioid tolerant as well is really important. Go through the non-pharmacological strategies that have had effectiveness for this patient. Once again, chiropractic, acupuncture, some alternative methods of helping to treat pain. Really important, because if something worked and then they stop doing it and they're in the same pain, why wouldn't we start back where something worked, right? So you don't have to reinvent the wheel sometimes, you just have to ask the questions. pharmacologic strategies that have worked, what NSAIDs have worked, what haven't. A really good reconciliation is important. And fortunately, in the Salt Lake Clinic where I practice now, we have a clinical pharmacist. She's actually filtering through all of our clinics within the Intermountain system, and she has been incredibly important when it comes to patients who come into our clinics that are on a number of medications. And we need to do a reconciliation because polypharmacy, especially in our older population, is a big problem, especially when you add in an opioid or some neurodepressant medication. So always talk about what's worked, what hasn't worked, and where you've been, so we don't repeat previous mistakes. And then barriers to previous treatment strategies. Going to physical therapy is costly, it's time consuming. So how can we optimize that for a patient? Are there any free services that are available? Once again, mental health. So psychology in particular, very tough to pay for that. The mental health, our medical system is not kind to. So I hope in the future there's more ability for patients to be seen from that standpoint. Okay, PDMP, we go through it again. Right now there's 54 in the United States. Well, at the time this was developed, 54 active working PDMPs throughout the United States. So in 2019, I think 84% of hospitals had adapted a PDMP into their EMR. And then it was something like 66% of clinics have integrated it into their EMR. So hopefully you all have found it to be easy to use. In the IHC system, it's been integrated into the power chart, so it makes it a little bit easier than going to a separate site and querying that. And there's usually a surrogate that you can place under your license or under your practicing your medical practice that is able to look that up for you. So your MA, your assistants can look that up in advance if someone's calling in and give you that information, so it's not as time consuming for you. There's the appointed delegate. So multiple prescriptions from different clinicians is predictive of opioid misuse. So once again, if you query that PDMP, you see multiple prescribers. In our system, it actually says how many prescribers, what the MME is, and you can see patterns. And so those are opportunities, as I would say, to really have discussions with those patients. Obtaining complete psychosocial history, obvious. We want to kind of screen for mental health issues. Depression, anxiety, like I said before, all predictive of worsening pain or someone with pain having worsening symptoms. You want to look for alcohol, tobacco, illicit substances, other drug use, so that you know kind of what you're getting into, especially when you're prescribing a controlled substance. The social determinants of health. So all of these and the CDC and the NIH all kind of harp on this because different access equals different kind of patient care and different experience. So you kind of want to know the economic stability of a household, where they're from, culturally, everyone has that different background. And so the more you know about your patient, the more empathy that you can provide, but also understanding where they're coming from can also help direct treatment more appropriately. So you want to seek some objective data. So a good physical exam, important, right? So you're having low back pain, let's check your low back. You're having radiculopathy, let's check a straight leg raise. Let's do some things where we can get some objective data. And then obviously we have other diagnostic information, MRI, CT, X-rays, all very, very good for helping you come to a diagnosis and then a treatment plan. Neuro exam, very important as well. And then we have a lot of assessment tools in our armamentarium, I should say. And there's really good pain assessment tools. Just a BPI or the 5 A's are all really easy, quick to be given out in your clinic. The functional assessments, the short form 36, the geriatric assessment, pain intensity, enjoyment of life, and general activity is the PEG. I don't use that one, but I probably should. And then adverse childhood experience questionnaire. That one's really important to kind of identify those factors that are not kind of on someone's face, but have happened to them in the past. Okay, that concludes my segment. Is it Dr. Minori? Dr. Minori's interventional pain PM&R trained with a pain background, and he's at Park City Clinic with IHC. Yeah.
Some more space here. Make sure that this works. There we go. Okay, all right. So we'll get started here on chapter 3. This is creating the pain treatment plan. So just want to go over some of the objectives for this. Really, we want to apply assessment results to create kind of an individualized treatment plan, including, as we've all been harping on, functional goals, okay? We do want to identify evidence-based practice, so non-pharmacological options and non-opioid options. We want to align the treatment approaches, if we can, and it's difficult, to the specific type of pain someone may be experiencing, and kind of correlate precautions and considerations for opioid use in special populations. We'll talk about that. We want to identify common adverse events, drug interactions with opioids, which is very important, especially in different populations of people. We want to identify characteristics that influence the choice that we may make for an opioid, and demonstrate the ability to document well patient care using informed consents, patient-provider agreement that is required when we do consider prescribing opioids or taking care of patients in pain. So this is just kind of a nice slide to look at to begin with here. Basically, pain can be modulated anywhere, and we talked about this with Dr. Romankowski along ascending and descending pathways. In some cases, you can decipher where most of the pain is kind of firing from or coming from. And if you can do that, then you can kind of directly impact the pain, maybe even with very little medication, but it's oftentimes extremely difficult to do this. You kind of want to think about how pain is transmitted through the body always, as Dr. Romankowski talked about, and use that to determine in partnership with your patient how maybe to best manage them, because it's going to be individualized. I'm sorry for everybody. I wish this was cookie cutter when it comes to pain, but it's far from that. Chronic pain must be managed, not necessarily resolved. You know, I tell people I have no magic wand, I don't hit home runs, but it's really important to take that approach with patients, and you want to set realistic expectations from the get-go. That's very important. Have discussions with your patients about treatment goals, again, expectations that focus on improving function and not the complete elimination of pain. You know, having pain and still functioning is a very real possible goal, okay, for a lot of people. So this is just kind of components of a multimodal treatment plan. And the idea here is to establish kind of the cause of pain, initiate non-pharmacologic or non-opioid therapies first, and then regularly assess. So really, it's a comprehensive pain treatment plan. It should be developed and customized to the needs of each individual. Treatment plans should include the goals of the treatment, obviously, so the types of therapies planned, and an explanation of the patient's role and the healthcare team's role and responsibilities. Goals of treatment should be based on, again, the first thing we think about is, you know, an overall reduction in pain, but really improvement in function, outcomes impaired by pain, and someone's quality of life. And again, as this slide indicates, a multimodal plan including non-pharmacological and or pharmacological approaches is often what we want to go with. Overall, treatment approaches and plans should be well documented. It's very important, your documentation. And always come back while we're a physician, right? Or while we're treating people. We want to be, you know, we want to be we want to be advocates for them, show empathy. We want to collaborate with them. Give compassion. Effective communication is very, very important, and still using evidence-based practices. So the point is to keep our patients safe, ourselves safe, and the community safe, okay? So this slide here has got a lot going on, but I really do like it. It diagrams kind of a details of a multimodal approach, kind of impacting the pain continuum, which implies successful use of these tools, and you really should consider all of these tools and kind of mixing them in there. We obviously want to reduce pain, but we really want to cultivate well-being, improve quality of life, and restore function. And I kind of like the two in the middle there, you know, self-care versus clinician care. I talk about this all the time with people. You know, there's active and passive treatments. Actives are easier. You know, come in, you lay down, I put a needle on your back, or here's your medication. But really, we want to focus on, you know, the passive. What are they doing for themselves, okay? And lifestyle modification if we can, all right? So here, these are some evidence-based non-pharmacological treatments. Regardless of the pain type, these approaches should really always be considered, okay? These approaches have been found to be effective alone, but what I like to include them in a comprehensive plan, okay? So you're not really relying on these by themselves, and I tell people that. I'm not just gonna send you to physical therapy and say, good luck. It's gonna be part of the plan though. And some of these may be more applicable to some conditions than others, but all of these options are worthy to consider, and they do have evidence, each one of these, to support them. So again, this slide, Dr. Romankowski did an amazing job with. So we did talk about this earlier. And there was a theme here with some of these slides, and I just want to make a side note that medications listed on some of these slides, they're in alphabetical order. Please don't, it doesn't imply preference or anything there. So with this, just touching briefly on a few things. Nociceptive, inflammatory pain, we talked about some of these options. One thing with topicals, which is interesting, they always think about topical over the counter, but there are compounding pharmacies there, and we can compound different medications. So then you can kind of spread through maybe multiple sections of pain by combining different types of medications. But just be aware of cost. Every pharmacy cost is different. Even Jolly's is a big one, but if it's location based too, so cost can change just based on location. So some patients this might not be an option for, but please consider. And then, kind of jumping over to neuropathic pain, we think about that all the time with just medication usage, but interventional strategies, there's a lot of technology always coming out. And we're always trying to target pain, neuropathic pain, either from a central standpoint or either peripheral. Neuromodulation now is coming up, it has been for a long time, but both centrally, now peripherally with, stimulators and things like that. So just kind of thinking a little outside the box with a lot of different technologies where it may not just be medications when you think of neuropathic pain. Nocioplastic pain, it's kind of a tough one. And there's a big little, something different on the bottom of that where it says kind of no opioids, so bring your attention there. Try for the most part, if you can identify this pain state, you really want to try to avoid opioids in this population. So Dr. Romankowski did give a couple examples of some disease processes, one in particular fibromyalgia. We do know that people with fibromyalgia, they do have reduced mu receptors. Availability within the regions of the brain that normally process and dampen pain. So sometimes these medications aren't as effective for them, and then you're getting all the side effect, the risk, without a lot of the benefit there. Also, nocioplastic pain, this is pain that arises typically from altered nocioception despite no clear evidence of actual or threatened, like Dr. Romankowski said, tissue damage or evidence of disease. It's a multifocal pain. It's widespread. You have augmentation of the central nervous system, pain and sensory processing, and then you have altered pain modulation. So you get this amplified pain signal, you have an expansion of receptor fields, and then you have decreased descending modulation. So it's a really hard thing to treat. And then he talked about mixed pain states as well. So I think of that as someone maybe who's had spine surgery and everything looks great, and then they have continued pain ongoing. So it's really hard. These are very hard things to treat. So with this slide, again, another one we saw earlier here, it kind of complements the points Dr. Romankowski made earlier about the nature of peripherally mediated pain. If the pain source is peripherally mediated, you may treat it a different way versus centrally mediated. These are just some options here, but again, the central nervous system is usually always involved. It's usually not clear boxes of one versus the other. But sometimes you can identify it earlier. If there has been an injury or some tissue damage, you may want to just start on the left side first and get those medications going before you add in the other things, okay? With this slide, before prescribing anything, every healthcare provider should take all of these characteristics into consideration. Most of these apply to any drug itself, but some of the ones at the bottom are tailored a little bit more towards opioids. And then at the bottom here, the FDA has compiled prescribing information for all opioids on the website. So that's a very important resource itself there to come back to. And that's kind of one of the main points of this slide, is to be able to have that resource up. When to consider a therapeutic trial of an opioid. This information here is in line with the CDC guidelines. Everybody should consider all pain management options and prescribe opioids only when kind of the non-opioid options are inadequate, or when benefits of using an opioid are expected to outweigh some of the risks. sometimes you can coin this and they talk about a therapeutic trial, and you're trying to really build in the expectations and understanding when you start these medications. So you'll try something, for a short period of time, we're going to see how it goes, and if it's not working, we're going to stop it, just like all other medications, blood pressure medications and everything. I tell patients, if your doctor wanted you to stay on this blood pressure medication, wasn't doing any benefit, would you agree with that? No, but when it comes to pain, it can be difficult because these can affect different parts of the body and have different positive effects, not just treating pain. And also you want to define the word work, right? Not just what works, but you got to determine goals. You have to know what are we using these medications to achieve? Not just a decreased pain score. Functional gains, we talk about that all the time. Quality of life, improved ADLs, but specifics. I spend time, even awkward silence time, asking patients, what are some of the specific examples that you have, and how do you use this to improve exactly what? Well, I can spend more time with my family, or I can now cut my grass. It took me 3 sessions to do it, now it's only 2. So those are actually real things that we can monitor, okay, as opposed to a pain score. So this slide here, just a lot of potential risks. We start off with, it's always kind of doom and gloom here, but we will talk about some benefits too as well. But virtually, it's vital to fully consider the risks of using opioids prior to starting treatment. There was a systemic review, 2018, and a meta-analysis looking at 12 studies, and they looked at the incidence of new cases of opioid use disorder after treatment of prescribing opioids, and it was very close to 5%, which is a pretty good number, pretty high number when we talk about this stuff. So just be aware of that. But there are people that benefit from opioids. So maybe, they're very effective in the acute setting, post-surgery, an acute bone break. Also work well for patients who may be unable to take opioids. We know people who have a lot of comorbidities and they just can't tolerate other medications. Also suffering, particularly at the end of life, so cancer type pain. And then they can improve function for certain conditions. We're going to kind of switch gears a little bit and go into some assessments for risk. This slide kind of identifies contemporary commonly used tools to assess risk of misuse. There's no one screening tool or instrument that you can rely on to predict those patients not suitable for opioid therapy. So just keep that in mind. Presently, a combination of strategies is recommended to stratify risk, identify and understand aberrant drug-related behavior, and to tailor the treatment accordingly. All patients being considered for opioid trial, really you need, we all mentioned this, Norm did too, you should check the prescription drug monitoring program. And probably initiate one of the tools from the top first section. If you have a patient with a history of substance use disorder or you suspect a problem, there's where you may include 1 or 2 of the tools from the bottom part here. And then all patients on chronic pain for whom you might need to have long-term therapy, we really need to get a baseline urine drug screen. Okay, it's extremely important. Next, we're going to jump into one of these tools a little bit more detail. This is a closer look at the opioid risk tool. It's a brief 9-question measure to classify a patient as either high or low risk for misusing prescribed opioids. And I like the top right there. I want to draw your attention there. Substance use disorder history doesn't prohibit treatment with opioids, but it may require additional monitoring and expert consultation or referral. So really getting your team involved if you have an option. And the resources are hard, right? Pain psychologists or psychologists that have subspecialized in pain who understand this, or even addictionologists are extremely hard to find. But it's really important if you have those resources that you consider them. And I talked to our pain psychologist about some of these tools, and he told me about a study in 2009 that looked at a bunch of patients in a pain management center. They looked at the ability of some of these tools to predict aberrancies. So overuse of medications, drug use, and at the end of the day, the sensitivity increased tremendously when you included a clinical interview. So if you have resources and someone's not substance abuse, but they've been on them for a long time, you're not worried about that. If you have these resources of a psychologist to be involved, please expand your team when it comes to this. Don't just rely on a tool like this, because it can be enhanced with a clinical interview by a professional. So the next slide here, this is just a real brief one. If you want more detail, you can focus in on the scan QR code. This just kind of looks at categories of opioids, naturally, semi-synthetic, synthetic. We know our agonists, our partial agonists like buprenorphine, and our antagonists. So I don't want to spend a lot of time on this. Opioid side effects, adverse events, very important. So opioid analgesic medications carry risks not present with most non-opioid analgesics. We all know that. Risks of misuse, addiction, respiratory depression, overdose, death. Please note, items on the left, these are known or acknowledged common side effects, and on the right, you can see these are your adverse events, which are serious, medical consequences. Just opioid-induced constipation, that's the most common side effect. So please put in place kind of a mitigation plan for your patient when you start some opioids. It is your responsibility to be knowledgeable of how to weigh these risks before you prescribe an opioid, and about how to properly manage patients who are prescribed opioids, both short and long term. This is an even bigger one for me. So opioid-induced, I think all of us, respiratory depression. This is the number one most life-threatening situation with opioids. We want to use this information to educate patients, obviously, but also family members too, and signs and symptoms that they need to be aware of. You do want to reiterate, how to take medications, right? We want to swallow a tablet or a capsule whole. We don't want to alter the form, and must co-prescribe naloxone. Some of the big ones for me, it's more likely to occur in elderly population. Also with other drugs, we know that depressed respiratory depression, so benzos, patients who are opioid naive, or even dose adjustment. And you might not be adjusting dose, but if you see a prescription where it's one pill every 4 to 6 hours, you're not doing it, but that patient might be. So taking one pill every 4 hours for 6 hours is a big swing, okay? And then also too, I have some patients, and we use this as a positive thing too. They come in and say, I've used any in the last 4 days, and well, how about the day before? Oh, I had to use 2 or 3. That's a pretty big swing, right? Where they feel like they're doing well because they're not having to use it all the time, but having these infrequent days of use really fluctuates your swing of the metabolites in your body. You can have issues with that. So just a teaching point there for people. And then don't overestimate dose when converting. So please be aware of that when you convert from one to another. So with this slide here, basically, we're talking about drugs that interact. These are common to opioids, interactions common to opioids. Other CNS depressants, which we talk a lot about. Partial agonist or mixed agonist, antagonist. Anticholinergic, sedating, like tricyclic antidepressants. And then, muscle relaxers, right? I hate the term muscle relaxer. We could just get rid of that because there's only one muscle relaxer that we have that works at the muscle spindle. The rest work centrally. So dantrolene is the only one that blocks calcium at the sarcoplasmic reticulum. They're all centrally sedating. Even though a patient may say, oh, it's a muscle relaxer, it's just working on my muscles. That is far from that. So here, safer use. Here we talk about knowing drug interactions, pharmacodynamics, kinetics. Kinetics refers to the movement of the drug throughout the body. Dynamics is the body's biological response to the drug. Just be aware certain opioids with MAOIs can cause serotonin syndrome, tramadol particularly. Methadone, we can increase prolonged QT interval. And then some products rapidly can release opioid. We call it a dose dump when exposed to alcohol. So that's another reason, besides alcohol being sedating, we worry about this dose dump phenomenon that can occur. Opioids, CYP450 enzyme interaction. This reiterates the importance of knowing the specific product information before prescribing. Consider the effect of other medications the patient's been taking, and just be aware of patients come in now with pharmacogenomics, that may be used to predict an individual patient will respond to a drug. They are available nationwide, but payment can vary with insurances there. So again, looking at specific forms here, transdermal, transmucosal, special considerations with this delivery method. Again, don't cut, don't chew, don't swallow either form. Also note that you can have an increased dose exposure with these with temperature changes, so warm temperatures. So people use hot tubs all the time, saunas, hot packs, and that can change the dose exposure with this. So just keep that in the back of your mind too. So we're gonna, again, jump to the next section here. This is looking in at special populations. So there's some special populations you require special consideration when prescribing opioids and their benefits. So first here we'll talk about kind of older individuals. The complexity of managing care in older patients with persistent pain really does call for a multidisciplinary approach. Older patients do have a lot of other medical problems that can increase the risk of opioid-related adverse events. Respiratory depression is common in older people who are maybe cachectic or debilitated. Also you have altered pharmacokinetics. We talked about that, what that means, but it's due to poor fat stores, muscle wasting, so you have altered clearance. Also, it's more likely to develop constipation. So again, please have something in place for a bowel regimen. And then, polypharmacy, again, they're on a lot of medications for other things. So you gotta really be aware of that. And there's a huge fall risk and cognitive change. So jumping in, women with childbearing potential. I wanna bring your point to here down at the bottom with the green. Women who are using opioid daily, the American College of Obstetricians and Gynecologists recommend buprenorphine and or methadone. I would maybe lean a little bit more towards buprenorphine if you had to choose. They recommend a universal drug screen for substance use as part of the care and to be done too at the first prenatal visit too as well. There's a lot of risks. Potential risks during pregnancy to the newborn includes low birth weight, premature death, neonatal death, premature birth, hypoxic ischemic brain injury, prolonged QT syndrome, and neonatal opioid withdrawal symptom. And the opioid withdrawal can be expected in half newborns of opioid-dependent mothers. So it's very, very prevalent. So we're jumping into the opposite pediatrics here. So really this comes down to this, the safety and effectiveness of most opioids in the pediatric patients below the age of 18 has not really been well established. Most of these agents are not indicated for pediatric patients. Some of the non-clinical studies that were done examining opioids in children focused on safe use in inpatient settings. Pediatric indications for chronic opioid use are primarily life-limiting conditions. Relatively few pediatric patients with chronic pain and non-life-limiting conditions should probably receive opioids. So this is just another, they kind of group everything together. We'll just touch briefly on these. Sleep disorders, don't consider an opioid as a sleep aid medication, okay? Be very cautious with obstructive sleep apnea. About 2/3 of patients who suffer from chronic pain also have poor sleep. We all know that, right? Every time you ask them, how's your sleep? Bad, not good. And a lot of kind of nerve injury stuff is primarily they feel a lot more at night when everything shuts down. The problem with pain and sleep is it's complicated because opioids themselves can fragment sleep or even break up the sleep cycle because you're using this for pain, but it's disrupting sleep, and if you don't have sleep, then you have amplified pain, so you're in just a bad washing machine. Wanted to stay on that. So dementia or other impaired cognition, pain evaluation, like Dr. Romikowski talked about this, should still be performed, just knowing it may not be as reliable, but you still do it. Pain must be anticipated a lot of the times. They can manifest as a behavioral finding or agitation. Talk to the family members about it. Don't just dismiss it. So, and next one here with obesity, I think this is a pretty interesting one. What's interesting about it and what I like about it is cytokines, right? We know those as pro-inflammatory mediators. They are found primarily in high quantities in adipose tissue, especially interleukin-6. So when you have a lot of adipose, you have a lot of interleukin-6. If you have an injury, you don't just send off a few soldiers to battle, you send in the entire US Army, okay? And your inflammation can go through the roof. So it's really important that way. We talk about orthopedics and joint mechanical of overweight with joint pain. That's very true too, but we also look in the spine as well of balances of the spine, how your spine is balanced. So when you change kind of body habitus in a way, it can offset the natural balance. Our spine was put together beautifully. We have those curves, kyphotic curves are meant to keep us in balance, especially our sagittal balance. So as our body habitus changes, it can put pressure on other areas of the spine. We might not feel that right away, but over time, that can lead to increased degenerative processes. So I use these other teaching points because it could be the one thing you say with the light bulb to get motivation going again. So another thing here too, renal and hepatic impairments, very important to know about those. because active and toxic metabolites of many opioids are renally excreted, so accumulation can occur. So we know this with overdose when taking it as prescribed. And Dr. Oki had told me an example of one of his patients the day I started, and it's never left my brain, where this patient is taking it as prescribed, but had, I think, the flu or was having some issues with their kidney they didn't know about. So they had overdosed. They had an overdose, even though they were taking it as prescribed. They never missed a dose. They took it at 8 a.m. and 8 p.m. every single day. So just be aware of that. It's very important. And then psychiatric and substance use disorders, a lot of the medications we use to treat that, you can have drug interactions. So your SSRIs, SNRIs, tricyclic antidepressants, be aware of that population itself. And then end-of-life populations involve hospice and palliative care medicine specialists as early as you can with that. Sorry, I'm taking a lot of time here. We're almost done, I promise. Informed consent. So this is just a general consent approach for any treatment. You want to discuss alternatives, discuss pros and cons, discuss uncertainties, assess patients' understanding, make sure they understand, so you're constantly educating, and explore patient preferences. Risks and benefits are not all the same for all pain medications. And then it kind of jump shift a little bit here. This is a telehealth module. It's a series of 4 short videos providing advice and strategies for efficient and effective telehealth visits with pain patients. There is actually CME that's offered with this, so if you'd like to take a picture or save it for later, the goals just help to improve your pain management telehealth visits because it is becoming a more common tool and a benefit to a patient who maybe can't get to your office. So I'll give you a couple seconds to get a picture of that. Good. Everybody got it? Okay. So patient-provider agreement forms, or PPA, it's the most common component. These are the most common components of the patient-provider agreement. Formerly, we used to call this the pain contract or the controlled drug use agreement. This should be in place before the first opioid prescription is given. You should review for compliance and understanding and document at regular visits. The way I explain this to my patients is, from the start, is these are expectations. Again, we're trying to set expectations. These are the expectations that I have as a prescribing doctor to all of my patients, and these are the expectations that you should have of me as the doctor prescribing. So it's a two-way street here, but it outlines expectations, and then we go into more detail about it when we review it. And then, so patient-provider agreement and non-adherence. This is a really difficult one. I think we all have trouble with this. So behavior outside of the boundaries of the agreement that we agreed on, the treatment plan. Typically, it's not necessarily advisable to dismiss or fire a patient, from your practice on your first move, okay? There should be some ethical considerations are important for the provider and patient relationship. And then it's important to think about this because it's going to happen. So you can kind of figure out a specific exit strategy or something in place and be prepared when it occurs, because it will. So, all right, well, I think that is it for me. I'm gonna turn it over to Joy here. She is this year taking over for Dr. Oki and gonna do an amazing job, so. Oh, one other thing. It is in the notes here. We have the option to take a short break, or we can keep going. We do often ask.
We can't hear you very well.
Sorry, we have the option right now to take a short break, or we can just keep going.
We started 30 minutes late.
That's what I thought. Okay. Perfect answer. I just have to say that, though.
All right, I'll try to get moving quickly. I know some of the content has some repetition here. So what I'm going to talk about, chapter 4, is really knowing how to manage your patients that you do decide, opioid is the right medication for them. You've trialed non-opioid medications. It either hasn't worked, they've had some side effects for that. They've tried PT, other conservative things, and opioid's really the next step that you're thinking here. And so we're going to talk about different opioid analgesics, abuse deterrent products that are available. Talk a little bit about opioid rotation and how that works, when to discontinue, when to taper a patient, and then when we should consult with a pain specialist or get addiction specialist on board. All right, so this next slide is talking about, initiating immediate release opioids. It's always important when you're starting someone that you're really using the lowest effective dose, okay? And then again, this is gonna be a trial period. We're not making any long-term commitments here. Before the first script, you wanna make sure that you have your patient prescriber agreement in place. You wanna make sure that you have a baseline urine drug screen and informed consent. And so always remember about naloxone too. This graph right here is just talking about the 1 and 3 year probabilities of continuing opioid scripts by day supply of the first RX. So you can see as the first RX is longer, there's more probability at the 1 and 3 year that you're gonna continue the medication, okay? And then reevaluation should really be done on a continual basis. And so it can be a little bit variable from patient to patient. But sometimes it can be as soon as a couple weeks if it's someone that you want to have close monitoring, a couple months, but just be aware of that. And then really use caution at higher doses. So if you're going to increase the dosage beyond 50 OME, that's something that you have to really weigh the risks and benefits. And then anything over 90, you really have to have a clear justification on why we're raising the opioids to that high of a dose. And of course here there are some exceptions to treating cancer pain or palliative care pain. So if you have a cancer pain patient that developed pain after the cancer, you should be consulting with a pain specialist, as there's some unique situations here and they could benefit from some interventional strategies as well. And so periodic continual assessment. And so Dr. Minori talked about this a little bit, but the main thing we're worried about is not just a number and saying, what percentage do you want to decrease your pain by? It's really those functional goals. I usually, on the first visit, I'll ask my patients, give me a list of 2 or 3 things that you want to work towards, whether that's spending more time with your children, being able to do the hobbies that you found really enjoyable that you can no longer do right now. And so that gives a better idea if we're meeting those goals that we had talked about. And then again, reasonable expectations. 100% pain relief is really rarely a reasonable goal or attainable. And then, they have to be willing to engage in other modalities. So opioids is one part of the treatment, and other conservative things like physical therapy, pain psychology if we felt like that was necessary, other non-opioid medications as well. And then really on a continued basis, we need to screen for the adverse side effects like Dr. Minori discussed about previously. And so for monitoring, you're gonna have the Doppel here in Utah as our controlled database. So you're gonna monitor that really every visit that you're prescribing the medication and every refill, just to make sure we know compliance, using the urine drug screen, reassessing their risk for substance use disorder, and then considerations for treatment modifications. So what do we do from here? Do we continue the medication? Do we taper? Do we transition to a different opioid, or maybe consider a long-acting? And so tapering, there's some key considerations when we want to taper or discontinue a medication. So if therapeutic goals are achieved, if they're not having any pain reduction, they're not having any improvement despite the opioid use, they might have an adverse event, an overdose event. That's one that to be taken really seriously. If we're worried about opioid use disorder, and if they have significant medical comorbidities that we're worried about. And then this is a slide briefly on, if you're considering rotating from immediate release to a long-acting medication. So There's some rationale for doing this. I would say in my personal experience, probably mostly I do this for cancer pain patients. But some reasons that we want to think about it is, sleep disruption is the number one thing that I can think of. If they're taking immediate release opioids around the clock, it's disrupting their sleep. This might be a better option for them. And so it just has more stable blood plasma levels, and it could last through the night so that they don't have to wake up in pain. And then, what opioid are we gonna think about transitioning to them? Well, to keep it simple, if they're on oxycodone immediate release and they do really well with it, then maybe just stick to the extended release, so go to OxyContin. Other potential reasons, the patient may want to try a different formulation. Sometimes cost or insurance issues can be a determination, and then if they have a change in clinical status or adherence issues. And so a couple other considerations. So I wanted to touch on fentanyl. So if you are considering transitioning someone to a transdermal fentanyl patch, really important to make sure that you can't use this formulation if they're opioid naive. So the lowest dose of fentanyl patch is 12 mics. And that's really equivalent to 30 oral morphine equivalents. And if you're taking into account like cross tolerance when you're transitioning, they would have to be at a higher dose for you to transition to this, probably around like 60 OME. So that's something, if your patient's taking Norco 5 2 or 3 times a day, like that's not a medication you'd want to start them on, because they could go have an adverse event. You could always consider transitioning to buprenorphine. We use that quite commonly in our clinic for its better safety profile. The patch can be a really good option for some of your elderly patients that you want to have that long acting effect, but you're just worried about some of the adverse side effects of the full mu opioid receptors, or medication, sorry. And then you want to monitor patients really closely for the first 24 to 72 hours of initiating the dose. So these are the patients that you want to have closer follow-up. And then packaged inserts can be really helpful, especially for the buprenorphine products. They'll give you some guidance on which oral morphine equivalence is recommended to transition if you want to do the buprenorphine route, or it'll tell you about different minimal intervals to titrate. And so I'm going to talk a little bit about opioid-induced hyperalgesia, as this can happen to patients when they're on opioids for a chronic time period. And I tell patients about this kind of before I take over their opioids or initiate an opioid. This is a phenomenon that occurs when someone's on opioids and they actually have increased pain from being on the opioids. So it's going to look like, someone that had pain in their back, and maybe that pain has spread a little bit more. They've been on opioids for a long time. They can be hyperalgesic on physical exam, and it doesn't really make sense. And then things that you're going to want to do, there's really two options. You can either go down on the opioid dosage, or you can rotate. I feel like rarely ever can I sell the let's go down on the opioids when they have increased pain. So I'll try to at least do a opioid rotation, and some patients get really good relief of those symptoms when you do that, and you can take advantage of that incomplete cross tolerance, and you can actually lower their oral morphine equivalents when you do this. And then opioid tolerance, so this is the concept that the drug at that same dose that they've been taking for a long time is no longer giving them the relief that they once had. And so sometimes this can look like addiction because, they're wanting an increased dosage because of the dose that they're currently at's not working. But those terms are different from each other. A patient is considered tolerant if they're taking these dosages, so 60 oral morphine equivalents a day, and then again, really caution with the transdermal fentanyl patch. And then this is where, again, you could do opioid rotation if you suspect opioid tolerance as well. And these terms, tolerance versus physical dependence. So again, these are not equal to addiction or opioid use disorder. So these are your body's physical adaptations to the drug. So tolerance is when you need increased dose to maintain, the same function and the same analgesic effect. The current dose is no longer working for you. And then physical dependence is, if you don't have the drug, you can no longer function normally as what you used to. And again, this can sometimes look like drug-seeking behaviors because they're wanting more medication. So just be aware of that. And then we're going to talk about opioid rotations. So this is what I talked about earlier, changing one opioid from a class and you're transitioning to a different opioid. And so the rationale is that there's different mu-opioid receptor subtypes, and different opioids bind either with a greater or lesser effect to the specific subtype than others. And so you're really taking advantage of that, and you're able to transition to a different opioid with a lower dose. You first want to do the equianalgesic dosing, and you can do this by using some tools that are out there and tables that you can calculate it from. There's some online calculators that you can use to do this. And so, yeah, either online calculators or some apps available. What you want to make sure, though, is that there is a lot of variability in these different conversion methods. So if you're going to use one, try to stick to one tool with your clinic so that you're using the correct calculations and you're not going to avoid like overdose. And so we're going to do an example. This is a test question. So we'll go over that so that we get it right. So you have an 80-year-old patient and they are on 180 milligrams of morphine a day, and you want to convert them to oxycodone. So how are we going to do this? So this is a table of, we're going to kind of focus in on the PO dosing here because I assume that's the majority of what we're going to use in our practice. So if you look at morphine and hydrocodone, those are a 1-to-1. So 30 milligrams is equal to 30 of morphine. And then oxycodone, you only need 20 milligrams to equal the morphine. So you could say oxy is 1.5 times if you wanted to convert it to the oral morphine equivalents. And so what you're going to do is you're going to take the 180, divide by 1.5, or you can either multiply it by 2/3, and you arrive at the 120 milligrams of oxycodone. And so that's not where you want to stop, though. And we'll talk about that a little bit later when we talk about incomplete cross tolerance. But that's to make the quick conversion, oral morphine equivalents to the other medication. And so this is the incomplete cross tolerance table that I was talking about. So you can see drug 1 and drug 2, there's different mu-opioid receptors, and the drug is binding to a greater degree to different subtypes, and it's variable in different opioids. So this is what we're talking about with not wanting to do just a straight conversion, because you could get into an overdose event if this were to occur. And so just know that there's a lot of different receptor subtypes. There's a lot of patient variability in how they're going to respond to an opioid rotation. And then to finish our example, so we already said that the direct conversion was 120 of oxy. And so you want to decrease the dose to account for that incomplete cross tolerance. And so it's kind of a wide range here. So it's anywhere from 25 to 50%. And just use clinical judgment. So if you have an elderly patient that's frail, has a lot of medical comorbidities, maybe you want to stick closer to the 50% versus someone that may not have those characteristics. So since we have an elderly gentleman, we are going to do the 50%, and let's go with 60 milligrams of oxycodone is the answer. And I think it's actually like 30 milligrams BID. Yeah, that's the right answer. And so here's some other guidelines here.
You go on ER to IR, or IR to ER, is that what you're saying? Because
In that example,
yeah, that's not what we do. We would go IR to IR and then.
so that was just a immediate release medication
I know,
example.
but you don't go IR to ER when you're doing the transition.
I think that was just all immediate release.
No, not here.
Oh, does it say extended release in the answer? Oh, it is ER.
Yeah.
But I would agree, I wouldn't do that as well.
Does it
And-
say-
Yeah.
Yeah.
It says ER as the answer, and that's their answer, but
I'm wondering if that was a typo.
That's gotta be a typo.
It might be a typo, actually.
This is the
Because-
exact same conversation that we had last year.
Okay,
Yeah.
maybe, was
So-
it a,
Maybe we'll chat, we gotta go through all the questions at the
Yeah.
end too, so let's come back to that. and
no,
chat
thanks for
about it.
catching that. I didn't realize it
That's-
said extended
that's-
release in the answer.
We had, we got this, back to the same,
You guys are on it,
yeah.
No, you're fine. Thanks for bringing that to our attention. Maybe we need to just talk about that for next time, so. Yeah. So for this next slide, we're gonna talk about switching to methadone. Again, with methadone, don't give to opioid naive patients. This has a little bit different pharmacological profile. It has a really long acting effect, and so really when you're starting this, you shouldn't exceed 30 to 40 milligrams a day when you do a rotation. You want to consider getting an EKG at regular intervals, especially if you're going to go up on the dose because of that QTC monitoring. And then if you switch to buprenorphine, there's different formulations out there. You can have microgram formulations, and then there's milligrams. So milligrams is the opioid use disorder dosing, and then micrograms is the FDA approved for pain, okay? And so depending on which one you choose, again, the package insert, I think, for Belbuca, which is the buccal films, is that they recommend going to 30 OME, going down on the dose on your oral morphine equivalents to 30, and then switching them to the buccal formulation. But just remember, those are micrograms, and so if someone is on a high dose of full mu opioid agonist, that's when you want to do your induction if you're going to do the milligram dosing for buprenorphine, because you don't want to cause like a precipitated withdrawal. All right, and so I think this is just another practice example. I don't think there's anything new here, but I think that's just a repeat. And then, so breakthrough pain. So when you have someone on like ATC, which is around the clock dosing, you have them on extended release. This is an important concept for cancer pain. So patients with cancer pain can have disease progression. They can have new areas of pain. And so they really need that stable baseline analgesic dosing with the long acting. And then if they're having like breakthrough pain is when you consider adding an immediate release on top of that. And so how you're gonna calculate that is use 5 to 15% of their dose, using that and then converting that to the immediate release to be given as needed. And so never use a long-acting medication for breakthrough pain, because that could lead to an overdose event. And then consider optimizing, if there's a risk of problematic behavior, or just make sure you're having routine follow-up like we stated prior. And then just know that there's some abuse deterrent formulations out there. This should be considered part of the overall treatment strategy. There's not really great evidence on this. It's sort of mixed, and they can be quite costly. Usually it's a formulation that has naltrexone, or like wax polymers in it, and that really deters the abuse. So like if they're crushing the formulation in order to snort it or dissolving it for IV use, this can be a deterrent. just know that it may not be covered with insurance. And so we're going to talk about urine drug screens. Just remember that this is done for the patient. It's not a punishment. It's just how we monitor what's taken, and that we can document everything appropriately, and then we can identify any misuse or any addiction. And then there's some variability in how often people do this. You know, I always do it prior to the first script. It's important that before you do the UDS on the first visit, you ask them exactly, you know, what the time and dose of the last opioid medication was taken, because different opioids have different lengths of time that they stay in the urine. And so if a patient is only taking it like once a week or a few times a month, like it may not show up in the UDS. So just because it's negative doesn't mean that they're diverting. So just make sure you have that accurate documentation before you get the UDS, just so that you know what to expect here. And so I think our clinic, we do it pretty standard, like every 6 months, unless of course there's like a misuse that's suspected or aberrant behavior, then you can get them random or on as needed basis. And then make sure, as Dr. Minora talked about, you discuss the results of the urine drug screen before, you know, you dismiss them from your clinic. Give them some time or a chance to maybe talk about things. Maybe there's an explanation for why a substance was in there that was not expected, or why there was a lack of substance that was not in there. And so usually an inappropriately negative urine drug screen can mean you know, drug diversion. Are they diverting the medication, giving it to someone else, selling it? Or are they actually overtaking the medication, and they're overtaking it maybe in the first week of the script, and then they've run out when you've taken the urine drug screen and it's not in there. So really pay attention to it in that detail. And then, so know what kind of drug screening that you have. So there is immunoassays, and then there's the mass spec. And so screenings, the immunoassays really screen for larger molecules, and the mass spec is smaller, so it's going to be more sensitive. So it has higher sensitivity, higher specificity, and you're going to get specific drugs and metabolites that maybe that screening is not going to necessarily give you, okay? So there's really low utility to doing the screening immunoassay in your clinic. It's really better to have that HPLC mass spec way to screen, because the immunoassay version, there can be a lot of false positives and a lot of false negatives, and also the mass spec has lower detection limits, and so you can really identify more drugs and metabolites. So understand what kind that you have when you're going to run it. Always make sure you check the temperature, and then explore unexpected results with your patient. And so this is just an example of how every drug has a different time that you would expect for it to be in the urine. So on the left side, how soon will it be positive after they take the drug, and then how long will it continue to be positive on the drug screen. As a general rule, most of the drugs in the urine stay like 1 to 3 days. There's some that do stay in there quite long. So marijuana, ketamine, PCP, those can stay up to 7 days there. So just be aware of that. And then cocaine is really rapidly metabolized to its metabolite. So you might not see that in there if they do cocaine. And then here's an example of opioid metabolism. Always be wary, or always know about what metabolites can go to what, because this is going to how you determine if they're taking the medication as prescribed. So if you see that 6 monoacetylmorphine, that's probably they just did heroin. And then know that poppy seeds in large amounts can go to codeine or morphine, and then hydromorphone in really small quantities, I think less than 10% of the morphine can get metabolized to hydromorphone. So if you see both of those and they're taking morphine, it doesn't mean that they were given a script for Dilaudid. So All right, and so other considerations, so we talked about reevaluating, making sure you look at the therapeutic goals. Are they managing the side effects, or are they not tolerable? And have they made progress toward their goals? And are the benefits still outweighing the risk? Some misuse behaviors you need to be aware of. If they're losing their scripts multiple times, say like, hey, my script got stolen, that's a pretty popular excuse that we've heard. If they repeatedly are obtaining opioids from different sources, usually you can check that on the DOPL or the control database. Those are some signs that you need to bring them in, discuss this behavior, because we're worried about an opioid misuse or opioid use disorder, okay? And then there is some data that shows that if they've had a previous non-fatal overdose, it really increases their risk that the next one, they'll die from it. So that's why it's really important that if they have a non-fatal overdose, you take that really seriously. Okay, and then tapering. So tapering should really be kind of a discussion with the patient, should be a shared agreement. So, it could be the patient comes to you and wants to taper because they don't want to be on the medication anymore, or if you both come to the conclusion that it's not being effective. And of course, if you suspect opioid use disorder, you need to start treatment for that. So that's using one of our medication-assisted treatments, getting them to see a specialist if it's something that you're not comfortable with. You can consider rotating them to buprenorphine, which is a really good medication for both pain and opioid use disorder. And then just be mindful of withdrawal. So you really want to slowly taper them. Patients that have been on high doses of opioids for years and years, this could take years to get them off. So it's not going to be like a month taper schedule. So just be aware of that it's really recommended as a slow titration, because we really want to avoid the withdrawal effects. Because if they do experience withdrawal, that just deters any future attempts at weaning. They're going to be scared and they don't want to do it anymore, and they might not trust you anymore. And then when to consult a pain specialist. So that's if you feel like you suspect an opioid use disorder and feel like they need to see an addiction specialist or someone specialized in buprenorphine or some of these products. If you feel like they've been on opioids for a long time but they haven't tried any interventional strategies, and their MRI has a bulging disc, or they have some arthritis there, some strategies that we can do to help interventionally to lower their dose. And then consult with your colleagues to see who the pain specialist is in that area, some good reputation there. And then it would be good to look for a clinic that has kind of an interdisciplinary, holistic approach. So someone that might have a pain psychologist on board, physical therapy, things that we can kind of treat them as a whole body approach. And then make sure you adequately document all your interactions. So this is not just important from like a medical legal aspect, but there could be a lot of different physicians and providers involved in their care, so it's good for them so that they're kind of up to date on what the plan is and they kind of know the situation and what's happening. And then chapter 5.
Right. Okay, so we're going to go into chapter 5 now, just educating patients and the caregivers. There is a lot of overlap with all this, so I do apologize if we sound like a broken record, but it's kind of the way things were designed. With this, we're going to identify effective communication strategies, educating patients and caregivers, safe use, storage, disposal of opioids, and administering naloxone. Patient education can help reduce risks. Obviously, we all know that, but that's really a critical aspect of prescribing. We want to make sure that our patients are educated at initiation, but also throughout the treatment. You never stop educating. So with this, we're going to look at a few things here: proper use, monitoring, side effects, safety, storage. There is a handout, so you can scan at the top right. This is a handout from the FDA, Patient Counseling Guide. It's a good resource. What you need to know about opioids, pain medicine, as part of a discussion with patients and caregivers. Also, the CDC provides a number of useful clinical tools, so you can find that CDC opioids, I think providers prescribing, and then clinical tools comes at the end. Be clear in your instructions about taking the opioid as prescribed, and adhering kind of to a dose regimen. Also explain patients they should try to use the least amount necessary to treat the pain for the shortest amount of time. And then we also want to talk, like Joy already told us, with safe tapering to avoid withdrawal symptoms, because that can really put up a barrier for future tapering. Be cautious not to use for a condition other than what you're being treated for. So that's really important too, to be clear with your patients that, you know, if you've had a spine surgery and you have pain down the back of your right leg that we can't control otherwise, this is what we're using the medication for. So if you go in for a dental procedure or you roll your ankle, you're not going to this opioid to treat that pain. We should talk about that and see if it's appropriate or not, or there may be other strategies for that pain. And then, you know, document too what you're teaching to patients and others who are going to manage the medications, and teach patients and caregivers about safe storage, as up here, and disposal is essential to protect the patient, but also their family and their loved ones as well. This just breaks up two categories here, further things to educate on: warnings, so safe administration, what to look for. So safe administrations, again, emphasize the need to protect the integrity of the delivery system itself. So we do not want to alter it. You know, if patients have difficulty with swallowing, I would refer to the package insert for more information on alternative methods to deliver the medication. Reiterate the importance of full disclosure of other medication or supplements, risks associated with alcohol and other benzos, and then advise your patients and caregivers to look for signs for potential opioid use disorder. Some of the ones I like from this here, I mean, cravings, unable to fulfill work obligations, taking more as prescribed, you know, never share medication or get medications from others. And then also, you know, you may see a lot of emergency room or urgent care visits for issues with breathing or respiratory issues. That should be a red flag as well if you see that. This is, again, we know this, the number one most life-threatening situation, and most likely to occur, as I mentioned earlier, in opioid-naive patients or when switching doses, increasing doses. Greatest risk when co-prescribed with other CNS depressants, benzos, and then, you know, again, educate patients and caregivers, and really educate that any little bit of sedation should be taken seriously, because it could then turn into respiratory depression very quickly. So just really make sure caregivers, family members are aware of that, and they don't take that lightly. And then ensure that everybody has their naloxone prescription. We tell them how to get it, we prescribe it, but then they show up, and when we ask them about it, they never got it. So just keep asking, making sure they actually did get that there. Oops, there we go. Okay, so this is really opioid poisoning. Seek emergency medical treatment if this does occur. Whether or not to call 911 or give naloxone is a hard thing to tell you either way. It's based on setting, with the setting that you're in. But if you do give naloxone, it doesn't mean you don't call 911. So they have to happen together. 47% of all fatal poisonings for U.S. toddlers over a 14-year period from 2005 to 2018 involved opioids. So that's a really big number. Naloxone itself, so Narcan, FZO, this is opioid antagonist that reverses acute opioid-induced respiratory depression. So it allows the overdose victim to regain consciousness and breathe normally. Just be aware that it reverses the analgesic effect, so they may go into withdrawal symptoms. There are videos online on YouTube on how to administer the different types with nasal spray, auto-injector, intramuscular. And again, it works by displacing the opioid off the receptor site. It works on the opioid that are in your system. It doesn't work on benzos or other types of sedating medications. Most commonly, it's delivered through the nares. And consider everybody's access to naloxone. We prescribe naloxone or make patients get that for every prescription. We don't. It's just if you're on opioids, you should have naloxone. Institutions also have pop-ups to remind you. We do it within Intermountain, so it's flagged every time, and it has no abuse potential. And in May of 2023, another one came out, and I hope I don't butcher, but nalmefene is another one that's available by nasal spray, but it is, just know that it is a much longer acting version than naloxone, so it acts a lot longer. And then disposal, yeah.
Why is that important? That it lasts longer.
Well, it'd be hard to, go ahead.
So 30 minutes length of action for naloxone. So in an overdose situation, you administer the first dose. 30 minutes later, they can revert back to having those opioid receptors covered by the opioid.
And especially with higher doses, when a patient's on high doses,
High
they may
NMEs.
need,
Repeat dosing is really a key point to that. So just because you administered one dose of naloxone, you have to stay with them. That's why 911 is so important, because they can go back into their respiratory depressive state.
And as the answer, give one, then wait, then give another if you're not getting a response to.
Or it may not be an opioid.
Or
Yes,
Yeah.
correct.
That's right.
very good point.
Those in the ER in there, stay away from them after you give them.
Yeah, yes.
When they wake up, they're gonna be.
Yes, very, very true. Good, no, that's a very important point. We could not glaze over that, so thank you, Dr. Ronkowski, very much. So where and how to dispose, just safely discard, any expired or unwanted, unused medication. There's a Disposal Act of 2014 allows, different places, mail back programs, maintain collective, receptacles at law enforcement, authorized manufacturers, distributors, and reverse distributors, narcotic treatment programs, hospitals and clinics also that have on-site pharmacies, and then retail pharmacies. And just really be sure, try to use authorized collection methods if you can. That would be recommended. Okay, so we have Dr. Hrushka again coming up for our last chapter here. Chapter 6.
Finally, we've arrived at the last chapter. All right, I'll try to get through this quickly because I think there's still more overlap. But so this chapter, we're going to really focus on how to recognize the behaviors associated with OUD, because up to 25% of the patients that are on chronic opioids long-term can develop this, so it's important to recognize this. So if you see this, to either start treatment or refer to a different provider. And so it can be quite complicated when you're initially seeing someone for pain and they've been on these opioids for a long time, and then they developed, or you suspect that they're developing opioid use disorder, but they still have pain and that hasn't changed. And so sometimes it can be really difficult managing both the pain and the opioid use disorder at the same time. And so just remember that opioids prescribed in the context of chronic pain can lead to addiction if they're taking for longer than what was intended. And so what's the definition of addiction? So the official American Society of Addiction Medicine has their definition here below, but basically it's just complex interplay between genetics and environmental and life experiences that predisposes someone to developing this. And then of course, it's going to be characterized by some pretty obvious behaviors that we'll talk about here. And I think Dr. Minori kind of talked about this in the last one, but so it's all about recognizing these behaviors: compulsion, cravings. They're not able to really fulfill obligations in school or at work. It's causing them harm. They're having, they don't recognize that physical hazards that comes with it. And then just notice here that tolerance and withdrawal are listed separately. So if they have tolerance and withdrawal, it's not valid in the diagnosis if they're taking the opioids as prescribed, okay? And then we've also touched about this a little bit. So these terms are not synonymous with the other. So just because they're having tolerance and physical dependence, so those are biological adaptations and doesn't necessarily mean that they're having addiction. So it's really looking for those behaviors in the diagnosis. And then also just being accurate in your terminology to reduce the stigma associated with it is important. And so what I talked about earlier, anywhere from 10 to 26% of patients can develop OUD, and specifically the chronic non-cancer population. So that's why it's really important to screen for it in patients that are on these dosages for a long period of time. Clinical judgment is really going to be the best deciding factor. But things to kind of look out for is if they've been on high dosages for a long time, low hedonic tone, not really getting any pleasure in life anymore in certain hobbies or activities that they used to do before. And then if they have coexisting mental disorders or past history of substance use disorder, these are all things to be watching out for. And then we're going to talk about opioid receptors in the brain. So Dr. Romankowski talked about this, but just really briefly, so your prefrontal cortex is the area in your brain that's involved in the decision-making, reasoning, and judgment, right? And then when you take an opioid medication, it works at different areas of the brain. So the periaductal gray is the pain center, which, we take the opioid and that's where we get the analgesic effect. And then this nucleus accumbens, the reward center, is where you get that euphoric feeling. So again, people that are susceptible to those feelings may seek the opioid for those reasons. And locus coeruleus is the area of the brain where you start to get those biological manifestations. So, and then there's different neurotransmitters in the brain that are involved. And so in addiction, it starts with binging, intoxicating yourself with the drug. And then, so that's the first stage in blue. And then when you get to the second stage, after long periods of time, you're no longer taking the drug for the euphoric effect, but you're taking it to avoid withdrawal. And so that's when you're going to see that second stage. They really want to avoid those withdrawal symptoms. And then you start to get into the preoccupation, that green area, where they start to have that impulsive and compulsive behavior that you see. And so these neurotransmitters, specifically, dopamine, those all, the rewarding effect of the medication increases dopamine, and so that's what they're ultimately trying to obtain. And so we have some medications to help with this. And so there's three main ones: buprenorphine, methadone, and naltrexone. And you can start this from your office. You no longer need like an X waiver for the buprenorphine that previously was required. And just make sure as soon as you recognize this that you start them with treatment, because these medications can really save lives. Buprenorphine is probably the most common one that we prescribe. And then we also do get that question, are we just replacing one drug with another? So, I've had patients ask me this, and they don't want to be on a medication, and they think that we're actually feeding the addiction. And so it's important to just educate them that we're not feeding the addiction, but it's treatment, kind of the same way that we treat depression with medications. And so this slide is about how buprenorphine works. So it's a partial opioid agonist at the receptor here. And so it's going to bind with a higher affinity than a full agonist opioid. And so someone here, so on that top left picture, someone's in withdrawal because the opioid receptor is not bound. And they start to have those unwanted side effects. And on the right side is when the full mu opioid receptor binds, and it helps with their withdrawal. They don't have withdrawal anymore, and they get that euphoric effects and the opioid effects. And so over a long time having this, they could potentially have OUD, And then those little yellow circles is the buprenorphine on the bottom left. And so this happens when you give them buprenorphine. So because it binds with such a strong affinity to the receptor, it's going to kick off any opioids that were surrounding it. And then it has a very long half-life, like 24 to 72 hours. So while it dissipates, it can still block the opioid receptors and decrease withdrawal effects.
I have a question.
Mm-hmm.
If it doesn't fit exactly to the receptor and has unlimited opioid effects, then why do you use it for pain?
Because it still binds to the opioid. Yeah, it still is an opioid agonist. It's just not to the full extent as, it doesn't cause like the euphoric effects as a full mu opioid, and there's also different opioid receptor subtypes that it works on.
Okay.
So, but yeah, good question. And so buprenorphine, so this is the most common prescribed medication that we use. We talk a lot about this plateau effect in regards to respiratory depression, but just still be cautious because, overdoses can still happen with buprenorphine. Just be aware of that. And so you don't need an X waiver anymore, and there's different formulations. So if you're using it for opioid use disorder, there's the milligram equivalents or milligram formulations that we talked about. And then these two products here on the bottom, they're approved for pain. And so you have the patch and the Belbuca films. Of note though, if you're thinking about starting someone on the pain formulation, so the microgram formulations, they can be quite expensive. So if I'm thinking about prescribing this for a patient, I usually run the costs with our pharmacist before I recommend it or give some recommendations, because sometimes they can be like a couple $100s a month. And so it may not be an option for some people. And then just making sure we're aware of this interaction here with the benzos. 30% of opioids or overdoses involve benzodiazepines, so that's why we're really careful about prescribing those two together. And then just like benzos though, any other sedating medications, even Lyrica, gabapentin, even those at really high doses can increase a respiratory event. And also like things like Ambien and other sedating medications. And then making sure that we're still, the approach for treating a patient that has opioid use disorder. Again, making sure that we counsel the patient that we are going to address both their pain and their opioid use disorder. So that's a lot of fear in some patients, that if they have that, then you're no longer going to think that their pain is real, and you're kind of going to forget about it, and they're going to be in pain, because pain can trigger an event for them to go back to the opioid or maybe go to the streets and get heroin. So be really careful about that. And then always consider a multimodal pain program, and then non-pharmacological options. So anything that we can do to kind of supplement. There's a lot of non-opioid medications out there that sometimes I'm surprised that patients haven't tried and they were started on an opioid first. So always just make sure that you give them all the options available. And things like physical therapy, yoga, acupuncture, cognitive behavioral therapy, these are all things that we can supplement in our treatment plan. And this is some resources if you want to take a picture. These are some training materials on the left, and then physician finders. So if you want to see how to locate like an addiction specialist in your area, these are the QR codes. All right. And so in summary, so we got to the last slide finally. So there's a place for opioids like we talked about, but just use caution and just remember, use multimodal therapies, use those validated instruments and screen for OUD, and then always continually reassess patients. Don't just be comfortable with being on the same medication dosage of opioid just because they've been on it for 10 years. So just making sure that you're reassessing them at every visit. Having a family or caregiver present can be really important as well. And then, of course, if you suspect OUD, either start treatment immediately or refer to someone that has some more expertise. And then now we're gonna do the test. Should we give some time for them? Or should just? Should I start? If we want, if you want to just go. Oh, do you guys need time to do the, or should we just go through the answers? Is it in here? So it's not in here.
Is this open book?
Yes, yes, we
Hey, one more question.
Mhm.
So what's been your experience using buprenorphine for pain management, primarily not for overuse disorder? You know, it just seems like I've got a number of guys that, you know, they were on opiates and then they go to the pain clinic and they switch them to buprenorphine, and none of them seem to like it all that much. They don't get adequate pain relief, they say. So.
I mean, I will just, Norm can go just definitely, but it can also be too, not just the medication, but also how you start, how you transition. That's pretty important too.
Yeah.
So there's a,
Sorry. Yeah, I'll have,
and then Norm, you can get it here.
how did he get this out of here? Just yank it. I mean, I'll pass this to Norm soon, but I'll just give a little plug. Like, again, incidentally, from the medication itself too, it's also how you start it, you know, that process of starting it. There's different strategies, I think, some better than others too, and we can go into that a little bit more detail. I'll hold for that right now and let Norm give his point. We can come back to that if we need to.
Just really quick, because you asked a good question too. I use buprenorphine more than any other opioid in our clinic. I've had a patient who came who was on oxy 30s, 20s, about 230 MME. We actually transitioned her to about 2 milligrams 3 times a day, and she was doing great. And so on that dose, because of how people metabolize different opioids differently, you may find that that can vary. Now, some patients, and I will tell them before transitioning, not everyone fits in a car. I don't fit in every car, and I'll explain that to them. However, if I am going to consider an opioid, if I have a patient with a broken back, and elderly lady, if we're going to consider something, sometimes if we have to consider an opioid in a person, sometimes I will do a low dose, either Belbuca or a low dose Butrans patch before going anywhere else, simply because the safety factor when I'm considering the patients. With buprenorphine's tapering abilities, it tends to be safer, it tends to manage pain better. From my experience, the more people that have used it, and you mentioned about how we transition is a big deal. I've heard of patients, and this is unfortunate for me, as I've looked at Doppel reports, some people have transitioned them straight on to 8 milligrams of buprenorphine without going slow in it. And I find that patients will do better as you go low and then go slow and then taper back up. So how you transition is important, and then considering appropriate dosages as well as other factors. Yeah.
Yeah, so would you go over again the dosage for an opiate naive patient with buprenorphine?
Okay, so with an opioid naive, so he's asking if we can go over the dosages for an opioid naive patient. I mean, so if you consider like a Butrans patch, typically 5 milligrams on a Butrans patch, like 5 milligram, equals about, people will argue, about 9 milligrams of morphine. And so, for instance, like we'll go 5, 10, 15, 20. So you're looking at a maximum 20 microgram patch as being about 36 milligrams of morphine equivalent. And so you take that into account. Now, I have patients who will be on a Butrans patch, and if they absolutely had to, they may use a tramadol or a low-dose oxycodone for breakthrough pain. I feel a lot safer with that, and if I'm using an extended release, I will actually consider using a Butrans patch.
I see routinely from at least one pain clinic for opioid naive patients. They start them on 15 milligrams TID. What do you guys start as the low dose?
Oh my goodness.
Yeah.
Wow. Man, shoot. You're talking about any opioid?
It's 15 milligrams more.
Oh,
TID,
man.
first visit.
Boy, I don't.
So what, the deal is you use the lowest dose.
So I would do that with someone I didn't like. No, I wouldn't do that. I would never do that.
Of course you would.
But, man, it's a great question. So if I absolutely had to, and I think about it, I have a lady with rheumatoid arthritis, and she actually,
70 kilograms.
yeah,
Okay.
so I actually use a 5 milligram or 5, and I go as low as I can and say, man, do you really have to, only use this if you absolutely have to. And she uses it maybe once a week for her rheumatoid arthritis flares. Great question.
Oh, I think you might.
Just anecdotally, and I want to hurry as bad as the rest of you, so I've done this almost 30 years, and most of the people that you see in a chronic pain clinic have been in chronic pain for 30, 20, whatever years. And they know what works well for them, they've been on almost everything, if not everything, and Butrans is the weaker opioid, or buprenorphine is. And that's why a lot of them will say, hey, the oxycodone just worked better for my pain. That's why the multimodality is so critically important, and that's why you might have an adjunct, like maybe with peripheral pain type, that sometimes I see that the Butrans patch can be really helpful for. But there's just, and like you said, one size doesn't fit all. I'd like to see you in a Volkswagen.
He just barely got into the elevator up here.
Smart. Can we go over the test?
Yes.
Okay, so number one.
Yeah.
For the people.
And I somehow missed it in the discussion, when you're starting someone on an opioid therapy, do you do just a baseline drug test, or do you complete lab workup and social?
Yes.
Can you guys talk into the microphone?
Oh, yeah, urine drug screen is what I do, and so with our clinic, we don't prescribe on the first visit, and
Which
so.
question are you on?
Oh, it was the gentleman back here had a
I
question.
know which question.
He's
No, he's
asking.
he's looking at the test.
At the test.
Oh, at the test?
Yeah.
Yeah.
Let's start with
Question
number
10.
Let's just go with number one. So which comorbidity?
All right, so number one, which comorbid condition may predict the development of chronic pain following acute pain?
Yes.
Exactly.
Could you repeat the answers, please, and stand up?
Can you?
Yeah, so number two, I'll do that. Pain secondary to post-herpetic neuralgia is what type of pain? That's correct. We're going to pass it down. Do we all have
Okay, number three, which of the following is an anticipated outcome of a patient taking a prescribed opioid medication as recommended? Tolerance, yes, the answer is C, tolerance, that is correct.
What
Oh.
did you guys say for two? Because some of these can have two answers.
So for two, we said neuropathic pain, that's post-herpetic neuralgia. Yep.
Yeah.
B,
Sometimes they have that on top of a failed back.
sure, and that could be a mixed type of
Yeah,
pain,
you got a mix.
nociceptive, neuropathic, even some nociplastic pain in there. Number four, what is the first step in assessment of a patient's pain who complains of burning and tingling in his lower extremities? Hey, you're right. Yeah, let's do a complete history and physical exam to determine the cause of his pain. A. Okay, number five. Which of the following is the most important thing to consider in creating a pain treatment plan? D. Correct. The goal is to improve functional outcomes. We harped a lot on that today. I'm happy everyone said D. Okay, number six, which of the following is the best sequence for establishing a pain treatment plan of care? A. All in conjunction, that is correct. Establish the cause and type of pain. Initiate non-pharmacological or non-opioid strategies or therapies regularly and reassess. Okay, number 7, what side effect of opioid therapy should always prompt proactive treatment? Hey, very good. Yep, we want to start someone on a stimulant or some sort of anti-constipation treatment.
Diet.
What's that?
Silicon S, diet.
Yep, yeah, all of it. So A, constipation, that's the correct answer. Number 8, in which of the following circumstances is the patient at greatest risk of life-threatening respiratory depression from opioid treatment?
D.
Okay, so we have some mixed answers here. We have an answer of C, which is when converting dosage from one opioid to another, or D, are the two that we heard, when co-prescribed with a benzodiazepine. Both very important, but the greatest risk is when co-prescribed with a benzodiazepine. So D is the correct answer there. Although C is correct in a sense that you want to make sure that you're giving the lowest dose possible, and you've got to account for that cross tolerance. Okay, so number 9, select the correct statement regarding counseling a woman currently on chronic opioid therapy who is contemplating a possible pregnancy.
B.
B. B is the correct answer. For pregnant women with opioid dependence, switching to, so ACOG would say switching to buprenorphine is safer and more successful than detoxification. So number 10, after determining that non-opioid therapies are inadequate for a patient's pain, which of the following are the 3 most important things to have in place at the beginning of a trial of opioids?
C.
C, yep, in conjunction once again. Very good. Patient-provider agreement, or an MMA, or however you want to say it. Baseline urine drug test, and informed consent. And they kind of go back to a previous question. What else do you get when you're starting a patient on opioid? You know, if they have renal issues or cardiac issues, I think a complete metabolic panel is not an inappropriate thing. Any other lab data, you know, looking through the medical chart to see what other comorbidities are affecting this patient. So those all come into account. So I sometimes do that. Okay, so number 11, keeping in mind that official opioid use disorder diagnosis requires at least 2 criteria. Which of the following is a diagnostic criterion for the DSM-5-TR? Okay, a lot of mix there. So what we have is the correct answer of C, craving to use opioids. The rationale is,
But it asks for 2.
No.
so 2 criteria, so you have to have at least 2 criteria. Yeah. Okay. Very good. Number 12. In transitioning an 80-year-old patient from morphine, 180 milligrams per day, to oxycodone, and accounting for incomplete cross tolerance, which of the following would be an appropriate initial dose? We did this math with Dr. Hrushka. What do we think? A. But we have some concerns because we wouldn't really do an ER from an IR to an ER, and I would agree with that.
Yeah, it doesn't say.
What does it
It
say?
doesn't say if it's morphine or IR.
In the question, in the initial, yeah, and in the lecture as well. But let's assume that it's an IR. We would do 60 milligrams IR, however it was appropriately spaced out through the day. Okay.
And I think the importance of that is just the calculation part
Right.
there.
Right.
Regardless of.
Go down
IR,
that 50%.
It's just going through the calculation.
IR versus ER.
But it doesn't specify in
I
the
know,
question
so
to
how
know,
would you
so.
answer
It's a bad question. We'll email core reps.
Yeah.
We'll talk to it.
So
Ah,
you're,
no.
so you guys
That's
are
clear.
on an ER?
Yeah, so we're gonna say that the correct answer for your test is A. Okay. Anything lower than 60 could be appropriate as well if you really wanted that answer. Of the following, which is an appropriate reason for tapering and discontinuing opioid medication and not a situation that calls for further inquiry and increased monitoring?
C.
C, very good. Yeah, therapeutic goals are achieved. Number 14, what is the most important piece of information when educating patients and their families about naloxone use?
D.
D, very, very good. Very important. If naloxone is administered, you're calling 911, you're doing this concurrently, you're having family members, whoever's present, calling 911, administering, calling 911. What? Norm, you got something? Go ahead.
Just really quick, if you are administering, I had this happen in a clinic, and I would say, everyone knows the sternal rub. It's something that football players do a lot when they pile on each other. I had a patient though, she wasn't waking up. And so one way to kind of tell and kind of provoke a little stimulus is to do a sternal rub and kind of create that little noxious pain stimulus in him. And I would do that and she wouldn't wake up. So we did administer, we got her, and then I would do it and she'd be like, ah! So I had to administer the second dose. And I was like, man, this really works. I kept doing it. I hate to say I was kind of enjoying it. But the response, but you get that, ah! And then she would stay awake longer and you start to see the effects of the second dose stain. But co-administering, or well, I shouldn't say co-administering, stand by the patient. Realize that you should have multiple doses of naloxone. You may have to do this again and again and again. But 911 should be immediately called with that.
Yeah, because they'll have more doses and appropriate care, obviously. So that's all the questions, correct? Okay. All right, thanks guys. Thanks for attending. Sorry that was long-winded and we started a little late, but really appreciate you being here. Hopefully we learned something, take away points. Thank you.